Welcome. In this session, we will be discussing about ocular hypertension, wherein the most important issues are determining the risk of conversion to glaucoma and deciding whether to treat or not. A glaucoma suspect is defined as an individual who has any one or more of the following: characteristic glaucomatous optic nerve or retinal nerve fiber layer changes without corresponding glaucomatous visual field defects, characteristic visual field defects of glaucoma without corresponding glaucomatous optic nerve or retinal nerve fiber layer changes, raised intraocular pressure without evidence of either optic nerve changes or visual field defects of glaucoma, or family history of or genetic susceptibility to glaucoma. And ocular hypertension, which we will be discussing in this session, constitute a subset of glaucoma suspects. Glaucoma suspects need to be monitored periodically to diagnose glaucoma early and initiate treatment as soon as possible, and they should be monitored with optic disc photography, visual field testing, and optical coherence tomography of optic nerve, retinal nerve fiber layer, and macula. As we have mentioned, ocular hypertension constitutes one of the four categories of glaucoma suspects, and ocular hypertension is defined as having intraocular pressure consistently above 21 millimeters of mercury with open angles and without either optic nerve, retinal nerve fiber layer changes or visual field defects characteristic of glaucoma. So patients with ocular hypertension have a high intraocular pressure but have no structural or functional deficits of glaucoma. Ocular hypertension is estimated to be 8 times more prevalent than glaucoma, and prevalence of ocular hypertension in various races is given here. And it has been seen in several studies that higher the baseline intraocular pressure in ocular hypertensives, more is the risk of developing glaucoma, and treatment reduces the risk of developing glaucoma by almost half. The risk of developing glaucoma increases significantly when the intraocular pressure is more than 24 millimeters of mercury, and especially when the intraocular pressure is above 30 millimeters of mercury. And in the landmark ocular hypertension treatment study among ocular hypertensive patients between 40 and 80 years of age having an intraocular pressure ranging between 24 to 32 millimeters of mercury, risk of developing glaucoma among untreated patients was 9.5% in 5 years, and the risk of developing glaucoma was 4.4% in 5 years among treated participants in whom the baseline IOP was reduced by at least 20%. And when primary open angle glaucoma develops in a patient with ocular hypertension, characteristic structural changes usually precede functional visual field changes, and this underlines the need to monitor these patients periodically with optic nerve photography and OCT in addition to perimetry. Several risk factors have been found in ocular hypertensives which predispose to development of glaucoma. In the OHTS, 6 risk factors have been identified, and these are important to remember. These risk factors include older age, higher intraocular pressure, thinner central cornea, large vertical cup disc ratio, optic disc hemorrhage, and a higher pattern standard value on standard automated perimetry. Other factors which have been found to increase the conversion risk in studies other than OHTS include family history of glaucoma, myopia, migraine, high or low blood pressure, and diabetes mellitus. The OHTS along with EGPS, or the European Glaucoma Prevention Study, developed a risk assessment calculator based on the risk factors mentioned to estimate the 5-year risk of conversion from ocular hypertension to glaucoma. And these are the two versions of the same online calculator, one being the point system in which we have to select the range of each parameter in which the patient's parameter lies, and in the continuous method we have to enter the actual value of the patient's parameters. In addition to determining the risk of conversion to glaucoma, the other important issue to decide on in patients with ocular hypertensives is whether we should treat them or not. because by definition, ocular hypertensives do not have structural or functional defects of glaucoma, although they are prone to develop them in the future. And as of date, there is no consensus yet regarding this issue. And when we are deciding whether to treat or not a patient with ocular hypertension, we should consider the age and life expectancy of the patient, presence of risk factors of conversion, and inconvenience, cost, and side effects of treatment. Cost effectiveness study in OHTS suggests treatment initiation in ocular hypertensives having a 2% annual risk of conversion to POAG according to the OHTS EGPS risk calculator. On the other hand, deferring treatment till conversion to early glaucoma is acceptable as visual functions are preserved in early glaucoma. But in this course of management, we need to detect development of glaucoma as early as possible so that we can initiate treatment as soon as it develops. IOP lowering in ocular hypertensives can be done either with medications or laser trabeculoplasty. We will discuss in detail the modalities of lowering IOP in later sessions. And in ocular hypertension, a target of 20% IOP reduction from baseline is recommended according to the OHTS. And a special circumstance in ocular hypertensives is development of central retinal vein occlusion or hemicentral retinal vein occlusion, for which raised intraocular pressure is a risk factor. And in these patients, IOP lowering treatment should be initiated in both the eyes to reduce the risk of recurrent venous occlusion in the same eye or in the contralateral eye. Whether an ocular hypertensive patient is treated or not, periodic monitoring of that patient is a must, and it should be done at intervals of 6 to 12 months depending on the risk of conversion with IOP recording, gonioscopy, visual field testing, and optical coherence tomography of optic nerve head, retinal nerve, fiber layer, and macula, and we have discussed these modalities in previous sessions. As we have already discussed, signs of conversion from ocular hypertension to glaucoma indicating the need for treatment initiation include optic nerve weight changes such as focal notching, asymmetry of cup disc ratio between the two eyes, and occurrence of optic disc hemorrhages, RNFL defects, and visual field defects. Differential diagnosis of ocular hypertension includes entities with raised intraocular pressure such as primary open-angle glaucoma, angle closure glaucoma, and secondary glaucomas. To recap the salient points, ocular hypertension is the occurrence of intraocular pressure more than 21 millimeters of mercury without the occurrence of characteristic glaucomatous, optic nerve head, or visual field changes. In the ocular hypertension treatment study, conversion rate from ocular hypertension to glaucoma is 2% per year, and this can be reduced to 1% per year by lowering the intraocular pressure. Risk factors of conversion from ocular hypertension to glaucoma in OHTS are older age, higher intraocular pressure, thinner central cornea, larger vertical cup disc ratio, optic disc hemorrhage, and higher pattern standard deviation values on standard automated perimetry. Other potential risk factors of conversion from ocular hypertension to glaucoma include myopia, migraine, high or low blood pressure, diabetes mellitus, and a family history of glaucoma. These conversion risk factors have been found in other studies but have not been established in OHTS. Differential diagnosis of ocular hypertension include entities with raised intraocular pressure such as primary open-angle glaucoma, angle closure glaucoma, and secondary glaucoma entities. Decision to treat a patient with ocular hypertension depends on age, life expectancy, and presence of risk factors in the patient as well as inconvenience, cost, and side effects of therapy. With or without treatment, a patient with ocular hypertension needs periodic monitoring with optic disc photography, visual field testing, and optical coherence tomography to detect onset and progression of glaucoma. Thank you for listening.